patients.
Couple patients.
2:30 to 6.
Okay. Yeah. I'm off to Florida.
Oh, today?
Yeah, tonight.
Oh, that's nice.
Gotta go, yeah. A little break.
Go down there and warm up.
I know. I think it's supposed to rain, I think. Welcome to Healthy Frontiers. My name is Dr. Bizzoni, and this show is dedicated to the education of our viewers. The topic tonight is physical medicine and rehabilitation. My special guest is Dr. Brad Cash. Dr. Cash has been practicing here in White Plains for almost 5 years. He's the owner of Spine Options and works hand in hand with many of the other medical practitioners in town. And so I'd like to welcome Dr. Cash to the show. Thank you. Cash, can you tell me a little bit about your background and how you got into physiatry?
Sure. I did grow up in New York.
Right.
And I went to college at Emory University in Atlanta.
Right.
And then I decided to come back to New York, and I attended medical school at New York Medical College here in Valhalla. Mm-hmm. At that point in time, I had the tough task of choosing which specialty to pursue. Right. And at that point in time, I did decide that I did not want to be a surgeon, and I actually wanted to help people avoid surgery.
Okay.
So I did choose the field of physical medicine and rehabilitation,
right.
which is known as physiatry. Which is a specialty to study nerves and muscles and how they function together and the overall function
of the body, huh?
of the body and patient,
Okay.
and how we can help them avoid pains and improve their function after injuries or after strokes or surgeries, hip replacements, and so
Okay,
forth.
so physiatry, the word physiatrist really entails more than just working musculoskeletally, right, with the muscles and tendons and ligaments. I mean, if someone has a stroke, that may affect their body, and you guys can help them out as well.
Right, that's correct, Dr. Bizzoni.
Yep.
You know, there are many sub areas of specialty underneath the field of physiatry.
Right.
You know, there are those that specialize just in brain injury,
Mm-hmm.
and some that specialize in spinal cord injury.
Right.
Those that specialize in multiple sclerosis, those that help people with amputations, and those
Okay.
that help people after long hospitalizations.
All right, so physiatry is not just come in, get examined because I have back pain, which we're going to talk about in a little bit, which is a big part of many physiatrist practices, but it can help with other more serious ailments as well, right?
Right, absolutely.
Yeah.
My area especially is more related to the neck and back.
Right.
But when I did do my residency training at Mount Sinai Hospital in Manhattan,
Yep.
Of course we had to learn every area of the field,
Right.
and then decide which area to focus on.
Right, and that you felt most comfortable with that, and you were drawn to that for the reasons you had just said, help
That's
people
correct.
avoid surgery.
Right, that's correct.
Okay, so what's your unique approach to the diagnosis and treatment of back pain? Let's talk about back pain, since it's 80% of the world will have it at some point in their life, right? So
Absolutely.
it's a major malady. So tell me how you focus in on back pain.
Right. Well, back pain just in general is probably the number one reason why anyone goes to see their physician.
Right.
The second reason is the common cold.
Mm-hmm.
So there are many causes and reasons for back pain,
Right.
and neck pain for that matter.
Mm-hmm.
And what I try to do is try to help people figure out what exactly caused their pain,
Right.
and then try to help people treat their pain
Right.
with a common goal in mind of improving their pain symptoms and improving their overall function.
Right.
You know, while avoiding surgery.
Okay. Right. So I mean, that comes. You utilize medication when necessary, and or other types of alternative care, so to speak,
Right.
altogether.
Right, and my approach to evaluating a patient with back and neck pain is fairly comprehensive. You know,
Take us step by step.
right.
Go ahead.
You know, typically, a patient comes into my office. They fill out a 10-page form,
Right.
answering all types of questions about, when their pain started, where the location of the pain is, if their pain travels to their arms from their neck or to their legs from their back. They need to determine if the pain is worse in any certain positions, whether it be sitting or standing or lying down,
Right.
or if there's any activity that causes the pain. And then after the patient fills out this form, which they're usually not too happy about,
Right.
but it does
Gives you a lot of information.
it does give me a tremendous insight.
Right.
I take a very comprehensive history
Right.
of of other episodes of back pain, and what causes the pain, what makes the pain go away, when the pain occurs, if there's a certain time of the day that the pain happens, if they tried any medications, a lot of people like to try putting heat on their back. Some people try putting ice on their back. Then some people try to lay in bed all day, or for a week, to try to make the pain go away.
And everybody's trying these different things, and maybe someone has told them to try this, try that, and really you don't even have a reason or a cause to their problem until you totally evaluated by a professional.
Right, exactly.
I mean, I find it in my practice years before, patients have been in auto accidents, or they've had a fall off a bike when they were 10 or 12, and that was the start of a major problem that doesn't surface until they're in middle age. You find that often yourself?
Right,
yeah.
Right, because the slightest mobility or injury to the back or spine might cause a millimeter of movement, and then years later another small movement adds to the first one until finally you have this whole myriad of symptoms and injuries that kind of all add up and cause intractable pain.
Yeah, and the tissue just can break down, and it's done slowly, and it's not until the symptom occurs. Isn't that true that a lot of times the patient will come to the office, but there's been a lot of damage done at that point.
Right. Sometimes.
And without the history that you do this comprehensive history, you would have not even known about that.
Right. Once in a while, you see someone that fell when they were 10 years old down a flight of steps.
Right.
And they might have been fine for years, and then have a recurrence of symptoms that they had 20 years prior.
Right. And I know this is so important. It's such an important point for us, as doctors, to be able to get that comprehensive history, really, and find out. I mean, it gives us so much direction, doesn't it? Then we know where to take the diagnosis. We know the patient may need X-ray, if they may need an MRI. Correct?
Exactly. And then the next step of the history is a little more detailed. You want to try to find out if the patient has any numbness or tingling in any portion of their arms or legs, or if they have any weakness.
So what would numbness or tingling, tell the audience what that might indicate? If they have, say they come into your office, doc, I have tingling in my fingers, or I have tingling in my toes. What would that be indicative of, possibly?
Right. Very commonly, when there's tingling, it means that some nerve is being pressed on somewhere.
Right.
Whether it be in the neck or somewhere in the arm or in the legs.
Right.
It usually means nerve compression. And it's my job to help figure out where that nerve is being compressed, and what we can do about it.
Right. For example, somebody can come with tingling in the fingers, right, and it could be something to do with a wrist problem. Maybe they've been on a computer a lot, and it's what we call carpal tunnel syndrome, right? Or it could be from the neck, or there could be a combination, right?
Right. Exactly. Yeah. When you do have tingling in the hands or in the fingers, it can mean a nerve compression. It could be somewhere in the neck. It could be in the shoulder region. It might be in the elbow region, or in the wrist, commonly known as carpal tunnel.
Yeah, and it's not uncommon for you to have referred sensation or tingling from a distal point or a point maybe in the neck or the back for your feet, correct? Because a lot of people don't put those two together. That's why I'm trying to make that point.
Yeah, that's correct. And as a physician and through our medical training, we also have to keep in mind other medical causes of nerve compression.
Yeah.
And very typically, people that are having heart disease and heart attacks complain of tingling down the left arm, and it's often important to as the first step to make sure that it's not a heart problem.
Right, and even with a diabetic, for example, wouldn't that be true with a neuropathy in a leg or so? There's so many different symptoms that can mimic one another and mimic different conditions. So that, again, I go right back to that strong history and examination. So, before we go any further on that, why don't we just, since we're going to be talking about back pain in depth and when we might need an MRI or what have you, and some types of treatment like injections, if that's necessary, or medication, if that's necessary, just point out to us in the spine, what does the disc look like, and tell the audience what the vertebrae look like and how that nerve can actually be compromised in the spinal level.
So generally, this is the structure of a unit of the spine, and generally the vertebrae or our backbone gives us the support to stand up. Without the vertebrae, we would be like jelly, and we'd be on the floor. The vertebrae is all solid bone, in front, and in behind, the bone behind the spinal cord itself has all types of sharp, pointy processes, which help protect the spinal cord.
Correct. Also, the muscles all attached there, etc. Right.
Right, and there are also several joints which allows us to move.
Right.
If it was a solid block throughout, like it is in front, we wouldn't be able to bend and twist and rotate. So it's necessary to have these joints and all these small bones and processes to help the mobility of the spine.
Right.
The spinal cord runs directly through the middle of the vertebral column, and it's all nerves. It comes down from the brain all the way down to the lower back, and it is protected completely by the bones.
Right.
Then the discs are the areas of substance between the vertebrae, which they're soft jelly-like cushions. Some people refer to them like a jelly donut. They have a soft outside, and inside there's a jelly-like material.
Okay.
And when there are problems with the discs, sometimes they shrink in size and they lose their water substance and they dehydrate, and sometimes this jelly-like material comes out.
Right.
And may touch some of the nerves and cause severe pain.
Right.
The spinal cord that runs through the spine gives off sprouts of nerves or nerve roots that form the nerves that go into the legs and go into the arms. And typically nerves are like electrical wires.
Right.
They have an insulating covering on the outside, and there are fibers on the inside, and they're really like the power supply to the muscles. Without the nerves, our muscles don't have the ability to move.
Gotcha. Great. So sometimes these discs do get damaged, and even in this model here, you see there's a little bit of arthritic spurring taking place, correct? And that would what would that signify right there? Tell the audience.
Well, when you have damage to the disc and arthritic spurring or bone spurs from chronic long-term disease, what happens to the discs? They dehydrate and they degenerate. And they lose their jelly-like material inside.
Right.
And then the bones actually get closer together.
Right.
You can compare the normal disc to the
worn disc,
the worn-out disc, and you can see the space is a lot more narrow on the worn-out disc. And this is what can explain why people get shorter in height. Over time, the discs actually lose their jelly-like material,
right,
and they degenerate. Also, what you might see in a disc is a disc herniation. In this disc, the jelly-like material comes out the side and touches the nerve, and this is one of the nerves that goes down the leg.
Right.
And in this type of situation, the person might feel pain going all the way down the leg, in the same area that the nerve travels.
Great. Okay. And isn't it true that a person may have this gel-like substance coming out, and it may be a herniated disc, and they may show some signs of it, but we're really not sure that they have that until we have an MRI or a CAT scan, correct? So when do you decide that a person needs MRI testing as a physiatrist?
Right. Well, in the process of trying to figure out where the pain might be coming from, after the history, I conduct a comprehensive physical exam.
Right.
And in this physical exam, the things that are important to me that I look for are weakness in any one muscle area, numbness or tingling in any one zone of the arm or leg, and changes in the reflexes.
Okay.
And with the combination of these three things, it helps me direct towards any certain nerve or nerve root that might be damaged. And when I do see these types of symptoms, we're fortunate we have the technology these days to have an MRI to look at these things, and MRIs are certainly better than CAT scans in viewing the discs and the soft tissues and the nerves.
Okay.
And they do help us directly visualize if there's a disc out of place. Unfortunately, sometimes we have to do a CAT scan in those those patients with pacemakers or metal implants.
Right.
When an MRI could be dangerous.
And we'll do the appropriate test. Then also in your office, I know you do a lot of electrodiagnostic testing, EMGs, etc. Why don't you explain to the audience a little bit about that? I know that they hear terms like EMG and NCV and diagnostic testing electrically. What is that?
Sure. Well, by history, and if you look at multiple websites about EMGs, EMG is one of the most feared tests by patients. Again, fortunately, with technology, the tests have become easier to conduct. The equipment has become more sensitive, and the tests have been more tolerable to patients. What an EMG is, it stands for electromyography, and NCV stands for nerve conduction velocity or nerve conduction studies.
Okay.
And what it is it's a test of the function of the nerves.
Right.
If you're doing the back and the legs, it's a test of the function of the nerves from the back all the way down to the toes, and in the upper part of the body from the neck all the way to the fingertips.
Right.
And we might want to do a test like this if we suspect any type of nerve damage from any type of
compression at the spinal area, possibly, right?
Of any nerve.
Yeah.
For any of the symptoms that we were talking about.
Okay.
And it's a really useful test to complement doing an MRI or a good physical exam, because an MRI just merely shows the structure of the spine or whatever body part we're taking, but it can't tell you if there's any damage. It can just tell you how things look.
Right.
And the electrodiagnostic testing allows us to actually test the nerves and the nerve roots to see if there's any damage.
Right. So you get a more complete evaluation on that.
Right. And the test is really divided up into two parts. The first part are nerve conduction studies, where we simulate nerve activity by using an electrical probe, and giving the patient a very low dose electrical shock, and we record the activity with various electrodes, and we get a tracing on a computer screen. That's the first part of the test. And the second part of the test is using a very fine needle, almost the size of an acupuncture pin.
Okay.
And we put it in certain muscles, and we record the muscle activity.
Right.
There's also a tracing that appears on a computer screen, and as well there's a sound that comes out of the amplifier.
Right.
And there are normal and abnormal sounds that are associated with this activity.
Right.
So the test becomes very, very useful to complement or add to an MRI to determine if there's any kind of nerve damage.
Perfect. So then you know where to go with that.
Right.
And I know you also recommend medications in your office for acute pain, some medications for chronic pain. Just give me a little overview there, because you guys seem to have, you have to be able to do it all. I mean, you can do some medication if you need it, or you have other modalities that we'll talk about in a moment. But tell me about the medications for acute pain.
Right. If a patient comes in and they have a new back pain, from lifting a heavy object or moving their refrigerator or lifting their child out of a crib or changing the tire on the car, whatever it might be, and typically those patients come in, crawling into the office, and their back's in acute spasm. All the muscles are cramped up, and they usually do not have pain going down the legs, but sometimes they do.
Right.
But what we try to do to help them with their acute pain are three different types of things. One, we like to give anti-inflammatory medications to reduce some of the inflammation that might have occurred, during an injury that has torn some muscle fibers. If it was a severe strain, or even a disc slippage or herniation, the nerves and muscles tend to get inflamed. So we like to use an anti-inflammatory on a scheduled, regular basis, usually 3 times a day for a week or 10 days.
Okay.
We also like to use muscle relaxers to help reduce some of the spasms that are occurring, in all the muscles, surrounding the spine. The muscle relaxers also help patients sleep, so it allows them to be in a more comfortable position.
Right.
And then sometimes for patients in severe agonizing pain, we use some stronger controlled substances or narcotic style medications.
Okay.
just to really help them,
get some rest and let them heal.
Be a little more comfortable.
Okay, great. And sometimes you use injections. I mean, if say, when is that appropriate? Tell the audience when that would be appropriate to use injections for pain. And there are different types of injections. Maybe can you just give us a little overview of what's appropriate when?
Right. For a patient with acute pain,
right.
If they're coming into the office, usually within the first week or so, that when they have severe pain and spasm, with no symptoms going down the legs or going down the arms, usually we're not suspecting a pinched nerve or a slipped disc in the neck or back. If we're just seeing severe muscle spasm, frequently we'll give a very local injection in the office, very safe, not near the spine.
No anesthetic needed.
Or no anesthesia needed. Right. No TV or fluoroscopy guidance is needed. For these injections, usually just in the soft tissue and the muscles surrounding the spine, we usually give some type of steroid and some type of local anesthetic, almost like a Novocaine.
So it's a little deeper than that type.
Right. Yeah. And into the muscles to help reduce a lot of the pain and spasm.
Okay.
That's certainly the most simple type of injection.
Right.
When a patient has more long-standing pain and the simple medications and anti-inflammatories are not helpful, those people need more aggressive injections.
Right.
And people always talk about epidural injections.
Yes.
And that's probably the most common type. And typically what those are injections that have to and should be done under specific guidance, on a TV screen, where a camera's put in. It's called fluoroscopy, and those need to be done in the appropriate setting for safety.
So that can't be done in an office setting. It's more done in a surgical outpatient kind of setting.
Right. Some offices do have what's called a C-arm, which is the equipment that's necessary to do these type of injections. Right. And what they do is they use a TV guidance and they localize the area where the doctor thinks the pain is coming from and the specific nerve, and they take a needle with some type of steroid or cortisone, and they inject right next to the nerve tissue or by the spine to really help localize the site of inflammation and swelling, and they put the steroid in.
I think most people are so afraid that they're going to hit the nerve, and that's why it's so important to do it under fluoroscopy, right? So I mean, when you're going that deep.
Right. There are certainly possible complications with the procedure.
Right.
And fortunately, I haven't seen it in a few years, but I have seen in the past.
Right.
There's always a possibility of hitting the nerve and causing nerve damage. There's also a possibility of causing an infection in the area where people possibly need surgery. It's possible to hit a blood vessel.
So there are some downsides. So you try to avoid the deeper stuff if you can.
Right. But with a properly trained person with a proper technique, the complications are very, very, very rare.
Okay, great. So if you want a patient to avoid surgery, you go through these recommendations first. You obviously go through the injections. You have given the medication. And what other procedures might you employ in your office to help someone avoid surgery if they're having, say, chronic back pain that's really not being relieved with medication and or injection?
Right. Well, certainly medications and injections aren't always the answer. Sometimes they're just putting the Band-Aid over the problem.
Correct.
And what patients really need to do is, especially if they have a pinched nerve, is they need to mobilize the area and relieve that pressure.
Right. It's a mechanical problem, so you have to change it.
Right.
Yeah.
And that's typically done with sometimes different traction type machines can relieve pressure on the area and help the disc go back into place.
Right.
And with different types of physical therapy and chiropractics, especially, there are different manual or manipulative techniques that help relieve the pressure on the nerve.
Yes.
And unfortunately, it doesn't happen just with one visit.
Right.
Typically patients get treated 2 to 5 times a week.
Right.
With these manual techniques to relieve the pressure and help maintain it.
Sure. It's not going to. It may have taken a while to get to that point, so it's going to take some time to. And that's what a lot of people don't understand. It's not like a pill or a magic bullet. That it's going to take some time, and they have to participate. Isn't that true?
Right,
and give them exercises, you need to do them.
Right, and not only that, and as I tell all my patients, if you go to a physical therapist or a chiropractor or an acupuncturist or a massage therapist,
yes,
3 times a week for a half hour,
right,
that's 90 minutes of your week. There are 168 hours in a week.
There you go.
So those people also need to go home with their homework and do the proper stretching techniques and strengthening techniques, and also not do things that might
aggravate
and help, prevent their healing.
Right.
And usually it's not. There's usually not one technique that say this technique is the one that's going to make you better. Sometimes it's the right formula, the right medication, the right injection.
And everybody's different.
The right type of technique, and it's the combination of treatments that frequently works faster and more effectively than just one particular treatment.
Right.
And you're right, and everyone's different. And for those with multiple episodes of the same type of pain over the years, those patients are usually educated enough to know that their acupuncturist or their massage therapist or their chiropractor or physical therapist is the one that helps the most because they've had the most experience.
Right.
But for the new episode or most naive patient, you have to help them figure it out. It certainly makes my job easier when a patient comes in and knows which technique is the best for them.
Sure, you can direct them, and that's what your job in your spine options is, to just direct them to the right place and get the job done.
Right. I see people with neck and back pain all day.
Right.
And it's like figuring out the pieces of the puzzle.
Sure.
Figure out exactly where the pain's coming from and direct them towards the right specialty and the right modality to help them alleviate their pain.
That's great. Any final thoughts for the audience on back pain or neck pain, in diagnostic mode or in treatment mode?
Sure. I mean, kind of not unrelated, but and certainly very related to what we were talking about. Weight and body mechanics and posture are probably the 3 most important issues to address early on, especially as we age. And when we're teenagers, we can typically eat whatever we want and never gain weight. And as we age, when we start going into the second and third decade of life, we need to really watch our weight and our body posture and keep the midsection of our body very strong. With strong abdominals and posture, we're able to maintain ourselves and preventing back pain.
It's great advice, Doc. Dr. Cash, I want to thank you for being on the show. It was wonderful.
Thank you very much.
I think the audience got a lot of great information. If you have any questions for myself or for Dr. Brad Cash, you can look at our websites and email any questions, and we'll get the answers to you just as soon as we can. I thank you for being on the show, and we look forward to seeing you again.